I ran across a study that I found interesting, so I thought I would share with you guys. The American College of Lifestyle Medicine, the American Society of Nutrition, the Obesity Medicine Association, and the Obesity Society collaborated on a comprehensive advisory report titled National Priorities to Support GLP-1 Therapy for Obesity. Now, the report dives deep into the efficacy, side effects, nutritional deficiencies, muscle and bone loss, adherence to the medication, and the cost of GLP-1 medications. So I pulled out some key items that interested me. If you're interested in reading the report, I am dropping the link down in the description of this video. But here are the key takeaways. First, let's talk about efficacy. They point out in phase 3 clinical trials for obesity, the average weight loss with GLP-1 medication ranged from 5.3% to 17.8% over 56 to 72 weeks, depending on the drug and the dose. However, in real-world settings, weight loss tends to be more modest. For example, with the 2.4 milligram dose of semaglutide, individuals with diabetes lost an average of 8%, while those without diabetes lost about 11%. Now, most weight loss occurs within the first 6 months, slows thereafter, and typically plateaus by the 18th month. I'm just past 18 months, so come on, plateau. Now, on the flip side of that, weight regain is common when the medication is discontinued. About 2/3 of the lost weight returns within a year. And this is even when people continue with traditional nutrition and behavioral therapy. This illustrates the chronic and complex nature of obesity. It's not simply a matter of discipline or compliance. So then they go into about who responds best to this medication. And I found this to be really interesting. In a multivariate analysis, a method to analyze data involving multiple variables at once, for tirzepatide users, greater loss was found to be a likelihood in patients who were females, and that was 2.4 times higher odds of 20+% weight loss. People with a lower baseline A1C, and that is a 1.62% higher odds for weight loss. People without hypertension, and that was at 1.35 times higher odds. And those with a lower ALT level, and that is a 1.17 higher odds. For semaglutide, where they did a univariate analysis, which measures a single variable at a time, best results were shown in, again, women who lost, and they lost 48% more than men. Adults under the age of 55 with 24% more weight loss than those 75 or older. Individuals with a BMI that was greater than or equal to 40 who lost 23% more than those with a BMI that was less than 30. They also talk about the clinical benefits of these medications. A lot of these won't be a surprise. We've heard them over and over again. These medications provide so many different clinical benefits, but I'll go over them just in case. Beyond weight loss, GLP-1 therapies have been linked to improvements in cardiovascular risk and major events, heart failure related to mortality, obstructive sleep apnea, prediabetes and chronic disease, knee osteoarthritis, substance use disorders, and in metabolic associated liver disease. And they also went into the side effects. The most common side effects include nausea, experienced by 25 to 44% of users, diarrhea, experienced by 19 to 30% of users, vomiting, 8 to 24%, constipation, which I suffer from, 17 to 24%, and abdominal pain, which was experienced by 9 to 20% of users. They point out that these side effects often occur early in the process or during the dose escalation process and are more frequently reported with semaglutide. However, according to them, that may reflect differences in trial population rather than the drug itself. Now, I have heard from some users who have tried both tirzepatide and semaglutide, and they report that while the side effect profiles are the same between the two medications, the side effects on semaglutide feel harsher, more blunt than what they feel on tirzepatide. And this is potentially due to the tirzepatide's dual mechanism, where it is a GLP-1 and a GIP receptor agonist, which may balance out the side effects that people experience, making them less blunt than what is experienced on semaglutide. For nausea, the most frequently reported side effect, it often occurs in the morning and other long periods without eating. They recommend smaller, more frequent meals and avoiding high-fat or high-fiber foods the first few days of treatment to alleviate symptoms. Also recommended things like ginger and peppermint tea, increased hydration, and anti-nausea meds may also be useful. Also things like trying a smaller breakfast and then eating a small meal every 3 to 4 hours while drinking enough fluids. Now, these are all remedies that the community have been recommending, at least in my experience, my 18 plus months on this journey. The community has been recommending many of these things, if not all of them. For constipation, they say that it should be proactively managed, and they recommend the following to address that: increase fluids and dietary fiber, low viscosity, water-rich foods, that is like fruits and veggies, gradual fiber increase using prunes or dried fruits, limiting excess fat and protein. While fat and protein may slow digestion, which improves metabolism, it can also make constipation worse if you are experiencing constipation. So they say if that is the case, you may want to slow down on those things to help remedy the constipation situation. And then, of course, if needed, they suggest things like magnesium citrate, fiber supplements, Marilax, or stool softeners. Now let's talk about nutritional deficiencies. Calorie intake on GLP-1 therapies can drop 16 to 39%. Increasing risk for deficiencies, especially in women consuming less than 1,200 calories a day or men consuming less than 1,800 calories a day. At-risk nutrients include iron, calcium, magnesium, zinc, vitamins A, D, E, K, B1, B12, and C. Deficiency symptoms may include things like fatigue, hair loss, dry, itchy skin, bruising, poor wound healing, and muscle weakness. So if you're experiencing any of those things, you may be looking at a nutritional deficiency that you need to address. Now, personally, I take a bariatric multivitamin and a calcium supplement every single day to cover those gaps. And that is something that I learned from my bariatric journey. And the bariatric multivitamin, the thing that's specific about that is that many multivitamins don't also include iron, but a bariatric multivitamin will include iron. Now, my bariatric multivitamin provides 250% of the daily volume of iron, 24% of magnesium, and I get the other magnesium from my electrolytes every day. Now, back to the multivitamin, it provides 136% of the daily volume of zinc, 333% of vitamin A, 375% of vitamin D, 238% of vitamin E, 100% of vitamin K, and 41,667% of B12, and 144% of vitamin C. And then, of course, like I mentioned, along with that, I take calcium supplements, which also has vitamin D in it. Importantly, people with obesity may already have deficiencies due to poor baseline nutrition, altered nutrient metabolism, or restrictive diets. So nutrient management needs to be proactive and intentional when you're on a GLP-1 medication. Now let's get into one item that is often controversial and talked about a lot in our community, and as it's used as a reason why people shouldn't use a GLP-1 therapy, and that is muscle and bone loss. Now, the report points out, as it should, that rapid weight loss affects both fat and muscle, but rightfully so, they point out that this is something that's not unique to GLP-1s. That rapid loss can occur with bariatric surgery, it can occur with an illness, it can recur with other caloric restrictions. In the step 1 trial, 62% of the loss was fat mass and 38% was lean body mass. Because muscle mass is about half of the lean body mass, this translates into about 20% of the total loss from the lean mass being muscle. In the Surmount 1 trial, lean mass dropped by 8.5 percentage points, and modeling shows muscle loss in females was 10 to 15% of the total weight loss. Muscle loss in males was about 20 to 25%. Of course, this is in the absence of structured strength training. The loss of fat, lean body mass, and muscle typically correlates with the overall amount of weight loss and mirrors patterns seen with other intensive obesity treatments such as bariatric surgery or very low calorie diets. However, reductions in lean mass are also influenced by how strict the calorie restriction is, how quickly the weight is lost, and whether or not strength training is included. Inadequate protein intake, often due to decreased appetite, can further contribute to muscle loss and raise the risk of sarcopenia, especially in older adults, individuals in perimenopause or menopause, those with lower testosterone levels, those in sedentary lifestyles, or those not engaging in resistance or strength training. Rapid weight loss from GLP-1 therapy or similar treatments can also lead to bone density loss. Significant and fast weight loss, greater than or equal to 14% over a 3 to 4 month period, is strongly associated with bone loss, while slower, more moderate weight loss tends to preserve mass better. Bone loss is shaped by factors such as your starting weight, your age, your sex, your physical activity level, the degree of your calorie and protein restriction, and the speed of your weight loss. Older adults and women being particularly vulnerable. Without a structured nutrition and exercise plan, intermittent use of GLP-1s combined with weight regain or weight cycling can further accelerate loss of muscle and bone, which in turn increases the risk of sarcopenic obesity. So to reduce loss, what they do recommend is that you do strength training or some kind of resistance training 3 times per week, plus 150 minutes of aerobic activity. And that is exactly what I was doing in my active weight loss period of my journey. I was working out 5 to 6 times a week, doing cardiovascular activity and doing strength training 3 times a week. So I was doing that without even knowing it. And they also recommend that you ensure adequate protein intake. So what is adequate protein intake? They note that while 0.8 grams per kilogram of body weight is the general recommendation for adults, and that 1.2 grams per kilogram of weight is often suggested during active weight loss, the challenge is whether to base that on your actual current weight or your ideal weight or your lean body weight. And I've heard it stated both ways. And of course, they say that something that's less than 0.4 to 0.5 grams per kilogram is way too low, and to also avoid excessive protein intake, and that would be anything greater than 2 grams per kilogram of weight. Now, they do say that 1.5 grams per kilogram, 1.5 grams of protein per kilogram of the lean body mass is ideal. However, that would require body composition data. You can probably get that from a very good body composition scale, but I do recommend a DEXA scan so you can get a more ideal calculation. Absent of that, they recommend a general range that you shoot for somewhere between 80 to 120 grams of protein per day. And they say that can be a practical target for most people and easier for them to adhere to. So what is the bottom line? The report emphasizes that GLP-1s are not a standalone solution. For optimal outcomes, people should be paired with structured nutrition, behavioral support, physical activity, and strength training. Nutrient intake must be managed carefully to avoid deficiencies and preserve muscle and bone health during weight loss. Again, those are just some things that I pulled out of the report, If you are interested in reading it yourself, the link to this is posted in the description of this video. Let's talk about it in the comments. I hope you all have a great day.